So good morning, everyone. I would like to talk about pediatric viral infections, characterization of novel infections, and child-friendly approaches. I work at the first department of pediatric Semmelweis University, and I would like to create a safe atmosphere related to healthcare. I have two main ongoing projects. The first is about nasal influenza vaccination, and the second is about pediatric long COVID syndrome. So about my first project, nasal influenza vaccination for children is a non-compulsory vaccination. So first they need to see what are the main factors changing our patients' choices, whether they want to be vaccinated or not. So on the pro list, we can say that children under the age of 5 is at a high-risk group for severe infection, and they play a key role in transmission. But on the con list, we can say that these vaccination profiles are based on yearly predictions, so we should say that they are unreliable, and they need to be repetitive because we don't have a memory for further protection. And we also know that children have crowded vaccination schedules, which means that it takes a lot of time, money, and it's painful. So I needed to focus on what are the main things we can change, and I've searched for available things. And we have a fast and pain-free alternative for the injectable form, which is available for healthy children from 2 to 18 years. And there is a Cochrane review about the efficacy of the nasal vaccination, but they also, only conducted this on placebo or not active controlled trials, and they also said that adverse event data were not well described. So our question would be that are there any difference between the efficacy, the safety and cost of intranasal vaccination types and the injectable forms? And our hypothesis is that they are non-inferior to the conventionally administered forms in all ages of children, regardless of health conditions, and we will only use randomized active controlled trials. So under a systematic search and selection, we have 44 eligible studies. So my first results are based on the efficacy of the nasal influenza vaccine based on culture-confirmed influenza, regardless of strain, which means that after you are vaccinated for 3 or 4 specific strains, and after it you have influenza-like illness, you will get cultured, and they will try to isolate the specific strain you got infected by. And on our first results, we will see all strains. So regarding all years, because here you can see 15 studies, but they were conducted for 1 to 5 years. We tried to say results about efficacy, and our unit of measurement is odds ratio. If you can see results on the left, that favors nasal influenza vaccination efficacy. So our overall results for the first plot is that nasal influenza vaccination proved to be significantly better in case of efficacy, but you can see that the heterogeneity of these studies is high. So we conducted a subgroup analysis on studies where we had individual data on year 1 and 2 results. And you can see that there is a difference between the results, as there is no significant difference between nasal and the injectable forms, which is still good for us. So to see the differences and what is behind the high heterogeneity, we did a subgroup analysis on year 1, all strains, and we have a subgroup which is called respiratory diseases and another without respiratory diseases. And this is quite interesting that on the respiratory diseases group, we had a significantly better results on the nasal influenza vaccination, and without respiratory diseases, the efficacy was with no difference. And you can also see that on the respiratory diseases group, the heterogeneity was low. Based on secondary outcomes, all-cause mortality all were non-related to the vaccination, and we couldn't see any differences between the two groups. And based on serious adverse events, we have two subgroups, which is overall serious adverse events and related, and we didn't see any significant difference between the two groups. So our strength that we only used active controlled RCTs, which is the top of the evidence pyramid, and we also doing analysis on adverse event data with subgroup analyses. And our limitations is that we have high heterogeneity, but we try to make it out of a strength to able to say anything about the differences. So our main conclusion is that concerning the analysis on all years, all strains, nasal influenza vaccines were significantly more effective than the injectable forms in all ages of children, regardless of health conditions. Based on subgroup analysis on year 1 with respiratory diseases, so we could say that nasal influenza vaccines were significantly more effective, but on the other subgroup analysis, there were no difference between the two. Regarding all-cause mortality, which were non-related, and serious adverse events, there were no significant difference between the two. So implication for practice could be we should start, even in Hungary, school immunization programs to achieve herd immunity because it's faster and pain-free. And our implication for research could be that we should further investigate the differences between the subgroups, and we should try out new vaccine types which could be painless, like they started to do this with the COVID vaccination. So this leads to our second project, which is related to COVID. We already have a submitted article, which is the characterization of pediatric long COVID syndrome. When we conducted this study, systematic detailed studies were lacking in this area, and we wanted to be able to create specific case definitions and guidelines for providing good care for children. So our question was about the characteristics, and our main findings and conclusion was that although symptom-related conditions were detected only in a minority of children, the majority reported at least minor impairment to their quality of life. And we established the Hungarian Pediatric Long COVID registry. Now we have 340 patients with follow-up results, and we needed to move it to the Réka system, which is an internationally accepted platform for clinical trials and registries. And we have the follow-up data there, and we also started our control group studies. And we have 6 students who are doing the data cleaning now. So these are our goals. We have several, and thank you for your attention. Be yourself. Everyone else is already taken. Thank you.
I was just wondering about your long COVID registry. Do you plan to make it international?
We can plan it because from now on, we are available on the Réka system. And we are in an international group. So we started to work on it. Yes, thank you.
This nasal influenza vaccine is available in Hungary, and do you use it in everyday practice?
Thank you very much for your kind question. This is really good because it was introduced to the market this year. So after I started to do this meta-analysis, they introduced it to Hungary, which is really good because we really have the system to make it into like school vaccination programs. So yes, it's available.
I have a question related to your first project. In your second subgroup analysis, which is related to the respiratory and non-respiratory patient, is there any possible explanation for the different results in the two groups?
Yes, I was thinking about this a lot, and I found out that in the respiratory diseases, because they are really, I think, because they are really afraid of the serious adverse events, because this is why they might not want to take it, they had larger studies. So the first 3 on the top And on the without respiratory diseases, on the first one was conducted in more than 200 countries. And the other ones were single center studies, and the Krishnan et al. Was an Indian study. The Loeb et al. Was from Hutarit community, which is like an Amish group from Canada. So that's why we want to do further subgroup analyses to see what causes this heterogeneity in the without respiratory diseases group.
What could be the pathophysiology behind these nasal vaccines being more effective than traditional vaccines?
So it's debated, but they are trying to do researches on the fact that it might induce mucosal immunity as well, not just what injectable forms can do. And this might help us with, you've seen that I did my first results on all strains, and they are debating about that these nasal influenza vaccinations are better than the injectable forms in case of not the specific strains they are planned for. So maybe they will be better for not matching strains at the same season.
And what do you think self-administration of nasal vaccines could be an option in the future, possible way? Or?
Thank you very much. I think that it would be great, but I know that we are really afraid of reactions, immediate reactions, so I don't think so, because it contains a bit of egg, so this can cause anaphylactic reactions. But there are studies investigating whether there can be like pooled or mass administration. So like you go into a school, and I know it's hard, but when you go into a shop, there is these self-paying centers, and there is only one person who is reliable for the others. I think that will be like that. So you will be there. If something happens, you can go there, but lots of people can get vaccinated faster. But this is my idea.